start with the questions, if that's okay. And this is a question that's going to go out to all the doctors, and maybe we can start with Dr. Soni. So, oops. Uh-oh. All right, never mind that. I have my questions on paper here because I'm uber prepared. All right, the first question is not this question. The first question is, how has your HTC responded to the COVID-19 virus and are made changes in ways that would affect the patient? And how have patients responded to these changes? And also, if you could just add, are there a lot of cases of corona at your hospital? So if we could start with Dr. Soni and just take a few minutes to add that, that would be great.
Sure. At CIBD, we took a multi-pronged approach. One of the first things we did was to try to minimize patients from having to come into our center. So we have proactively called patients who were scheduled for appointments the following week. We screened them to see if they could do a telehealth visit, which we've been doing telehealth for some time. In addition to decreasing the number of patients coming into clinic, that also protects the patients as well as our staff. And then the patients that do have to come into clinic, they're not waiting in a waiting room full of other patients, so we're able to see them expeditiously. We've also split our care teams into two different teams. Three different teams, actually. We have a lot of staff that are Laker fans, so we chose Team Purple and Team Gold. Then we have a Team Teal as well. And each of the Purple and the Gold teams each have a physician, a nurse, a case manager that will be on site in clinic every day. So our teams alternate. So if we do need to see patients in clinic, we are available to see patients every day. We have a full team that's there. We also have other members of our team that are able to remote in and do a lot of Zoom telehealth. So for us, we've really tried to decrease the patients coming into the center, providing telehealth as well. A lot of the families appreciate the telehealth visits. It's more convenient for them. They don't have to find parking, come into the building, get seen, and then go home. So it's much more convenient. And we're also able to see the patient and as well as the parent. There are some places that do have limitations on how many people can come in clinic. And one of the things that we did as well is limit the number of parents and other family members. So we do just have a patient and the parent, or if it's just the adult patient, then when we just see the adult patient. So we're really trying to minimize the exposure that people have.
Have there been any changes as far as like if they need to go to the emergency room for a bleed or something like that? What is the advice that you give the patients now?
Yeah, so all of our emergency rooms are actually on very low census. I know in our ER at the Children's Hospital of Orange County, they've actually had to reduce staff because there's been less patients. So we reassure the families that the emergency room is not going to be as busy, and then we go ahead and call into the emergency room. Obviously, if we could see them in our clinic, we would prefer that as a controlled environment. And then also now at our Children's Hospital, as well as St. Joseph's Hospital across the street, and as well as the University of California Irvine Hospital, they do now check patients, temperature, ask questions as well. So there is also a built-in screening process at these institutions as well.
Great. Okay, thank you. Dr. Kwan?
So like CIBD, that we were proactively calling the patients and trying to reschedule them to, if they had inpatient or not inpatient, if they had appointments during the first couple of weeks. So we've been rescheduling the patients. More recently, when we're with UCLA system, so we're able now to do telehealth. And so since that has been available, we've been trying to call patients to let them know that, again, routine appointments are not being accepted in person. However, we are open to both urgent care and as well as emergencies. So if they need to have an infusion because of bleeding issues or something that needs an immediate attention, we will have them come in. And otherwise, we will let them know if they really want to speak to the physician or somebody in the clinic that we can do this remotely through either telehealth or telephone follow-up. And like today, for example, we had Cindy calling the patient to sort of give them advice on, in this particular case, it was a wrist pain, which could have been carpal tunnel. Erica has been talking to patients over the phone with regards to some of their psychosocial issues, work-related or lack of work and things like that. So we've been able to do that telehealth. So that has been going on. With regards to something, patients having to go to the ER, I have been trying to reassure the patients that, like Dr. Soni was saying, that the ER census actually has been down. I've had my colleagues posting saying, reminding patients that ERs are actually open still, and that if you have an emergency, you really do need to go. For example, in my case, I had a patient who, she's elderly, in her late 80s, turned 88 this year, and she was actively GI bleeding, and I told her she had to go to the ER because her hemoglobin was dropping from her normal to, she lost 2 units. And then when she finally went to the ER, I could see and follow her, and she'd lost another unit by that time. So
she was scared to go.
And she was extremely scared to go. She actually, when I spoke to her in clinic, she flatly refused to go.
Oh my gosh.
And,
Okay.
yeah. And
So what's
they
the
are really
situation? Yeah.
nervous. But to give them credit, what they're doing is that they're screening the patients that are having fevers or symptoms, and then triaging them to different areas. And then the patients who are not infection, they are putting them into rooms as immediately as they can to separate them. In addition, everybody that goes to the ER gets admitted actually gets a COVID test. So there's a rapid test.
Oh.
Yeah, everybody who gets admitted definitely gets both a rapid test as well as a PCR.
That's great.
Yeah.
And what's the status at UCLA? Are there a lot of cases or?
So the statistics according to the UCLA is that they've tested over 8,700 cases, or they've done 8,600 tests. About 670 are positive, with 133 admissions. And of those admissions, 84 have been discharged. The majority are able to go home.
Nice.
So 43 are currently hospitalized. So they give us these updates all the time. 11 are in the ICU with 7 on ventilators. So it actually is really high. If you think about it, it's a high number. About 20% actually need admissions, and 20% of those end up in the ICU.
Oh, wow. Okay.
Yeah, so
okay.
it is very serious. And that's why I understand, especially an elderly woman who's 88 does not want to get infected.
Yeah.
But at the same time, I can't have her bleeding out at home either.
Yeah. Yeah.
And so it's really important to remember and to reassure the patient that, yes, you need to be careful, you should wear a mask, but the ER is also wearing masks and trying to triage the patients to be as safe as possible.
Okay.
And I actually had on Monday an admission for bleeding. He actually is bleeding into his bowel wall. Actually, Dr. Soni probably knows the patient. Mm-hmm. He ended up getting admitted, and he is in the hospital. And again, they did the COVID testing and everything. So he's still safe.
Appreciate the update.
Dr. Young, what's going on at CHLA?
Sure. So we're taking a little bit of a different angle than the other 2 centers. So initially, we also sort of everybody went into a bit of a panic mode and said, okay, no patients come to the hospital, and cancel all the patients. But over the last 5 weeks, we've learned a lot within our hospital. And it turns out that our hospital environment is extremely safe. So we've done over 2,000 tests in patients at CHLA, and the positivity rate is less than 0.5%.
Wow.
We'll talk a little bit about children later, but children just don't, not only are they not actually getting sick when they get infected, it seems as if children get infected far less in the first place. Like they're not even getting infected for some reason. And there we could talk about that later, but there's data from different countries showing that. And then we also have screening. We have a fever. They screen them for fever, symptoms, and if a patient has those symptoms when they're coming to the clinic, they'll be directed to our drive-through, essentially, testing. So patients can go and have immediately a test done if they're experiencing symptoms and they've come to the hospital, not to be admitted. Of course, every patient gets admitted like UCLA gets tested. But we get a turnaround time of about 3 hours on that test. And so, in theory, this hasn't happened yet, but in theory, a patient could come to clinic, have some symptoms, be redirected to the testing area, which is in the parking garage, be tested, and then, sort of wait around, and within a few hours, they'll get the result. And if they're clear, then they can still come and be seen for their appointment if necessary. We have done a bit of telehealth as well. I saw 2 patients with Jennifer Duncan, our great nurse practitioner, telehealth on yesterday, when we had a clinic. But we are actually, based on the results of having this very safe environment, based on the fact that we're having this intense screening, based on the fact that everybody gets a mask. Even if you don't have one, you will get a mask for you and your child, for you and your children or your child if you come in. And so we've made the decision that we still think that in-person visits are important. You cannot do a physical therapy exam via telehealth. If you're having, if you're one of those people who has chronic joint disease or we need to evaluate your joints, you just can't do that via telehealth. We can't do x-rays via telehealth. We can't do lab testing via telehealth. So we still find a lot of value in the in-person visits. And so we're going to take the approach now that we've proven, initially we didn't know this, but now that we've proven that the environment at Children's Hospital Los Angeles, which is going to be different than an adult hospital, we've got a lot more sick people, potentially walking around. We've proven we have a very safe environment. And so our path forward is, for the most part, to continue our clinics as is. We also have a very large clinic space, and we have a new system where patients get roomed instantly. So they check in and then they get roomed. There's no waiting room. Nobody's waiting in the waiting room.
Nice.
So we have 14 rooms. We're doing basically 2 shifts, like an 8 to 10 shift in the morning, a 10 to 12, and then 2 shifts in the afternoon. So in theory, we could still see 50 to 60 patients in one day, and no patients are going to be stuck in the waiting room. So by taking this approach, we feel that the in-person visits have a lot of value, and we plan to mostly do those. If somebody prefers a telehealth visit, if we feel that we can do a telehealth visit, they don't need labs, they don't need x-rays, they don't really need an exam, then we're more than happy to arrange and organize a telehealth visit. I think in our place, most of the visits will probably still be in person, but if any family feels or any patient feels like, no, I'm a little more high risk, or I don't want to get out of the house, there's no problem. We can arrange for a telehealth visit.
Interesting. All right, thank you. Okay, so the next question, as you all can see, is for Dr. Soni. And now we're in week 6. At the beginning, I know a lot of companies said, don't worry about supply chain. We're in week 6, kind of no end in sight. Are we going to have a supply chain problem? What about plasma products? We're hearing a lot of issues with blood donations being, I see Dr. Kwan nodding, in short supply. And on top of all that, should patients be ordering more factor, more medication out of this concern?
Sure. So to my knowledge as well, following this, there does not appear to be any indication of any supply chain issues at the current time. In regard to plasma products, there are current availability of plasma products, but the concern is that if people are not willing to go donate blood or donate plasma that you may see an effect several months from now if there's a decrease in the number of people that donate. So if you can donate, please do donate. Blood donation centers are still open. We need many blood transfusions, whether it's for our patients with bleeding disorders or sickle cell disease. There's other people in the community that can utilize those blood transfusions. As far as ordering extra doses of medications, we still want our patients to continue their current medical treatment. So if they're on prophylactic medications 2 to 3 times a week or once a week therapy, we want to ensure they have at least a 1 month supply. Many times we'll try to order a little bit more, as much as we are allowed to by the insurance company. So it's really the insurance companies that are kind of limiting how much of a supply that we can give to the patients. But we think right now with the current good supply chain that's available, that a 1 month supply should be sufficient. But if we can always get more medications to the patients, the better. And then we also want to make sure that the patient and family also have all of their medications, not just the factor medications, but whether it's their diabetes medication, blood pressure medication, asthma medications. We want to make sure that all of their medications are in stock.
Have you heard of any other medications in back order?
I have not.
Just one
Yeah, Dr.
interjection.
Clark.
Yeah, oh, I just wanted to interject. So in anticipation, it was very interesting. Our pharmacist actually early in March was trying to get people to get 2 months supply, thinking because there might be difficulty with getting authorizations, that she tried to get 2 months authorized, and they denied it at the beginning of March. But then at the end of March, they actually said it was okay to get 2 months supply. And I think a lot of people, and you're nodding your head, yeah. So the Medicaid patients were allowed, and Medicare were allowed to actually get their 2 month supply, which I thought was really good, because you don't want delays with authorizations and things like that to cause people to not get their medications. And so I think that, at least from the pharmacy standpoint, that many of them have done a decent job. And just to reassure everybody, again, what Dr. Soni said, that there isn't any anticipated shortage of supplies, and that most of the manufacturers did say at the MASAC meeting that they have adequate supplies.
Thank you. That's good news. Okay, this question is for Dr. Young, and it actually has kind of come through the chat also.
Yeah, I see that.
Increased susceptibility for coronavirus. If I have a bleeding disorder, please include all the bleeding disorders. What are you seeing? People are worried.
Okay, so first thing, to allay concerns, there doesn't seem to be at all any reason why a patient with a bleeding disorder, and I'll touch upon the HIV immune deficiency part, but a patient with a bleeding disorder who does not have an underlying immune deficiency or any other condition that puts you at increased risk. So the bleeding disorder in and of itself does not put patients at increased risk of either contracting the coronavirus or of becoming particularly ill from the coronavirus. Actually, there's some information that, I can't say that hemophilia patients or other bleeding disorders in any way are protected, but I will say that one of the major problems that seems to be emerging is that patients with the COVID-19 disease are having very serious and significant blood clotting issues.
Right.
And many of them are dying as a result of the blood clotting issues, not even the infection, and some of them not even the lung disease. Now, can we take that to say that patients with bleeding disorders have some protection against that? I don't think we can take it that far, but I think we can say that your bleeding disorder in and of itself does not put you at an increased risk category for a more serious infection. And the comment from Jasmine R. I think I answered that. It says most information says heart, lung disease, diabetes. Those are for sure heart, lung disease, and diabetes are 1, 2, and 3 in terms of patients getting exceptionally ill with coronavirus, that along with advanced age. And yes, anticoagulants are now the standard. So patients who have a serious COVID infection are being put on blood thinners, currently at preventative doses, but it might move to higher doses. You know, how that's going to play into if somebody has hemophilia and they're treating with factor and they have a serious COVID infection, I think what I would say is keep getting your factor and then get anticoagulated, even though it sounds like you're, you know, battling the two of them, one against the other. But I think correcting the clotting defect and then having you be sort of like the other patients and then going on blood thinners would be probably the way to go. As far as immune deficiency is concerned, we often get concerned with infectious diseases and people with immune deficiency. However, it is not totally clear yet, but there are more and more anecdotal reports to suggest that, in fact, people with immune deficiencies are not getting particularly sick with coronavirus. And the other area where people are dying of coronavirus is from an overwhelming immune response. So the two ways people get really sick with this is if they get blood clots, and the other is where their immune response is having this overzealous overreaction to the virus. And so it's interesting that patients with immune deficiencies, and we've had some in our hospital, they're not really getting sick with this. And it could be that actually having a, you know, not fully functional immune system protects you from this overwhelming immune response that is leading to many patients to die. So, so that's the sort of long story. I'd say the short story, just to summarize, is no, people with any bleeding disorder do not seem to be at increased risk for either getting infected or getting particularly sick. Maybe they might even be somewhat protected. And the immune deficiencies at this point don't seem to be a concern, which is a little bit paradoxical. Usually with infectious diseases, we think that they are a concern. And then just to respond to Scott's, I want to respond to Scott's question, because I kind of alluded to this earlier in terms of, he commented about, you can all see it in the chat, social media, what's the actual percentages of people getting infected and subsequent mortality. I mean, what we know is that right now, the testing capacity in the US, although it's better, is still limited. So who gets tested? People get admitted to the hospital and people who are sick. And so by virtue of that, you're going to have a skewing of sort of the most sick patients getting tested, whereas the less sick patients or the asymptomatic patients don't get tested. The best study that's been done for this so far just got published in the New England Journal of Medicine, thanks to our colleagues from a small country called Iceland. And in Iceland, they have tested about 11% of the population of Iceland. It's a small population, but nevertheless, they tested 11% of their population. And what they found, which is similar to what was found in a couple of other countries, is that approximately 40 to 50% of patients who get coronavirus have no symptoms at all. They're completely asymptomatic. About another 40% of patients do get sick. I mean, they get the cough and the fever and all the symptoms you heard of. And then, the other 50 to 60% of those, and Doris already alluded to that, Dr. Kwan, that about 10% of patients who get coronavirus end up getting like really sick, and they get admitted to the hospital. And of those, a percentage end up in the ICU. And those that end up in the ICU they have a relatively high risk of death at that point. So as far as, what are we going to find in the long run when we have antibody testing? I mean, there's no question that the number of positive patients who've had this virus is going to go way up. There are two recent studies from California, one in Santa Clara County and one done right here by my colleagues at USC. And they've both demonstrated that in Santa Clara County, it was actually 80 times the number of patients who were tested positive actually are found to have antibodies. So that's a huge increased percentage of patients that actually have been exposed without knowing it. In LA County, it was about 20 times higher. So there clearly is a lot of patients who've had this and don't even know. And that leads to the final question about herd immunity. Yes, herd immunity is when enough of the population has the virus that it becomes harder to get transmitted because all the people who've been infected serve as a buffer. We don't know what the percentage of herd immunity is required for coronavirus. It varies from virus to virus depending on how contagious it is. But I mean, it's probably at least 60 to 80% of the population. So you're talking about a couple 100 million Americans at least will have had to have it to really have true, herd immunity. So we're far, far away from that. So I'll stop there.
Yeah, Dr. Young, there is one more question about just if you could address whether having an inhibitor, an active inhibitor, is something that would also put you at increased susceptibility.
Short answer is no. And I see a question about Hemlibra. That shouldn't put you at any increased risk either. And as far as another question about coughing blood from coronavirus, I mean, the patients with the coronavirus get really bad coughs. I mean, some do start coughing blood, but I would say that I wouldn't be too concerned overall about that particular symptom.
Okay. Thank you. This question is for Dr. Kwan. I think you already talked about it a little bit, other comorbidities. Some of us have them. What are you kind of seeing as to what they are? And then if you could also address the group of guys with HIV, Hep C, if they're at also greater risk if their HIV is controlled.
So my understanding, and Guy already actually alluded to some of the top significant risk factors to increase the difficult complications with having the coronavirus infection. Asthma or chronic lung disease, those are the patients that tend to have a hard time with the virus and the infection. Patients with diabetes as well as serious heart conditions seem to have a hard time. So those are the people that are at higher risk, but patients that are over the age of 65, it seems to infect those patients more. In addition, I think one of the risk factors, believe it or not, is just being in the nursing home, right? Because most of those patients tend to be elderly, and a lot of the outbreaks have been in the nursing homes. You see one patient in the nursing home gets it, and then everybody else, it's spread then to other patients by the healthcare workers who don't know because the incubation period is so long. And so even before the patient gets symptoms, they could infect somebody else who then takes care of another patient, and then that patient gets infected. And that's pretty much what happened in Washington State. And in New Jersey, they've also reported a number of nursing homes. So that seems to be a risk factor. Of course, travel, and that's why some countries have put a moratorium on traveling. Travel seemed to be a high risk factor, but in terms of actual diseases, they think people that may be immunocompromised. So in our population, there's patients who were infected with HIV. I think that the thought is, at least the thoughts are that if you have a low CD4 count, you might be at higher risk for developing complications, and those that are not being treated with antiretrovirals. So those who are stable on antiretrovirals and have more or less good or normal-ish CD4 counts, they should be okay and not at serious increased risk.
Okay, great.
So some of the things that, again, are really, if you have asthma, chronic lung disease, you should really follow your doctor's instructions and take your medications to have your disease well controlled. Like diabetes, the same thing. The other thing that seems to be increase your risk is severe obesity, but I'm not sure if that's related to the obese patients might tend to be at higher risk for having diabetes, high blood pressure, and coronary disease or cardiac disease, which seems to increase your risk.
I just wanted to add on to Dr. Kwan's statement about the nursing homes. I just read an article before this meeting that about 25% of the deaths in New York State are from patients that were at nursing homes. And I think they're going to see that number increase even more when they do the final tally.
Yeah.
Interesting, our Washington, D.C. advocacy trip was all about having elderly people with bleeding disorders be accepted into skilled nursing facilities. So maybe it is a kind of blessing that they don't accept us. Maybe
Right
we
now
won't
it
be
is.
pushing for that one right now.
Yes, good thing right now.
Okay, the next question is for Dr. Soni. There are a number of parents on the webinar. So what can I take or my child take for mild, moderate symptoms? I know we don't already take, we're not supposed to take Motrin, Advil, things like that, but can we take that? There seems to be mixed information, and you must know, being in Southern California, we're all about supplements, high dose vitamin C, vitamin D, taking vitamin K right now, zinc, garlic. Is there anything that's contraindicated if you have a bleeding disorder, especially right now? I think everyone's popping pills.
Right.
What are your thoughts on that?
Yeah. So as far as the first question, if a child has coronavirus type symptoms, one of the more common symptoms that child is going to have is fever. So yes, you can take acetaminophen for fevers. I would even be okay if people took Motrin as well. There was one study that may have been cited once, but then kind of as people researched into it a little bit more, saw that it was a little bit of a flawed study that said you should not be taking ibuprofen with COVID-19, but now data is showing that that's not necessarily the case. So if you are a patient with a bleeding disorder and you do take your factor medication as directed, I don't have any problems with intermittently taking Tylenol, and especially intermittently taking Motrin to try to decrease that fever. And it seems to be the fever that might be the bigger challenge. Again, if they have other medications, like if they're asthmatic or if they have diabetes, which we have a large pediatric population, unfortunately, for diabetes and obesity, that you should also continue to take your other medications as well. As regards to supplementations, fish oil has an anti-platelet effect, so I probably wouldn't recommend fish oil, but I'm not opposed to other supplements if people want to take them, such as ginger, which I know kind of also has a mild anti-platelet effect. But I think right now people want to have something that they have control over. So although we typically don't recommend a lot of supplementations, I think right now to have a sound peace of mind. Again, discuss it with your HTC team to make sure, but I think right now most supplements I would be okay with. Most of them probably don't increase the immune system, but if it's control, which seems to be what is most, which is a challenge in this situation, I'm okay with taking some supplementations, but you should run it by your HTC team.
Are you taking any supplements, Dr. Soni?
My wife did buy some multivitamin with extra vitamin C and some vitamin D. But as a good physician, I have not been very compliant with medications or supplementations.
Don't tell the patients that, Namit.
Got to be honest with the patients. We're human as well. But have I been drinking more orange juice and other things? My wife has been able to find things now that are a lot healthier than what we used to eat before.
You have a good wife. Dr. Young and Dr. Kwan and Erica, are you guys taking anything? Just curious. You don't have to answer if you don't want.
Just vitamin D.
I'm doing these little vitamin C shots. They don't taste good, but I just chug it in the morning, and that's all I take.
I'm good about my medications. Very compliant. 98% compliance.
Yeah, I mean, I've taken a little extra vitamin C, so we know that that's helpful against these types of respiratory infections. And I'm drinking more too, but not orange juice.
I'm drinking a lot more.
No, I'm
I'm
kidding.
sure that's what Dr. Young.
Actually, in all seriousness, I think alcohol is something that you can enjoy in moderation, obviously, but I'd be cautious about taking too much alcohol right now as well.
Because
So
of
that
the
was
blood thinning quality?
No, I mean, it's just, alcohol has a lot of detrimental effects. I mean, there are some
Oh,
positive effects with respect to red wine on heart disease and things, but
yeah.
all in all, alcohol is not, people who drink a lot of alcohol do suffer more infections, and it may not be purely related to alcohol, maybe their lifestyle or things like that. But I would just look, I mean, if you like having a glass of wine on a Friday or Saturday night, you shouldn't stop doing that. But if you're stuck in the house and and you're bored, I wouldn't reach for the bottle too often if that's the reason.
Got it.
Reach for the remote control and binge watch, as
You
somebody
hear
said
that,
earlier.
everybody? No, I'm just kidding.
Fair
All right, we got to move it along, and we are going to go a little over time. I hope that's okay with the speakers. If you have to get off at 8, please get off, but I feel like this is really incredible and valuable information. Okay, this is a question for Dr. Young. It's come out, if I'm on Hemlibra or maybe another non-factor product and I get admitted, what is this going to do to the labs that they're drawing? Is there something that I need to know?
Yeah, so I mean,
Or maybe non-HTC doctors need to know.
Sure. So I mean, I'll keep this fairly short, but I mean, Hemlibra definitely has significant impacts on the blood clotting tests that would be ordered by a physician who would be taking care of a patient with coronavirus. So the advice is, number one, if you're going to, if you do get sick and have to get admitted or have any lab work at all, make sure that your hematologist is aware and is involved. If it's not, in the hospital where you are getting your hemophilia care. If it is in the hospital you're getting your hemophilia care, obviously also make sure to say, hey, I have hemophilia, I'm taking this medication, please make sure you call the hematologist that's on call. So I mean, if it's within the hospital you're used to going to, just make sure that your hematologist or one of the hematologists gets notified. If it's outside that, then that's a different situation, and you need to let the doctors know, I have hemophilia, I'm on this medication called Hemlibra, you may not know what it is, but it does affect my blood tests, and please call my hematologist. So make sure that they get that you inform the other physicians who are taking care of you for the coronavirus in the ER in the hospital to get in touch with your hematologist. That's the most important advice I can give.
Okay, this is something that was floating around Facebook on some of the groups. People are saying, if you get admitted and you're on Hemlibra, you got to get off. The doctors are saying get off. Is that something that you would advise?
I would definitely not advise that.
Okay.
First of all, just so you know that Hemlibra lasts so long in the blood that even if you stop taking Hemlibra, let's say you stop taking your dose, tomorrow, it'll be 3 to 4 months before it's completely washed out of your system. And clearly the coronavirus is not going to last that long. So people are getting sick for, a week, 2 weeks, 3 weeks, maybe 4 weeks. Some people get sicker, it's a little bit longer, but either way, the Hemlibra is going to be in your system the whole time. There's no way to get it out of your system, nor is there any need to get it out of your system. Let's not forget that if you're on Hemlibra, it's because you have hemophilia and your physician has prescribed it for you to prevent bleeding. Right. So don't stop taking the Hemlibra, stay on it. If you get hospitalized due to coronavirus, obviously make sure your hematologist is involved, and then they can take a look at your case on a case-by-case basis and make decisions about, how to, if the Hemlibra needs to be counteracted, for example, because of the concern for thrombosis, then that's fine. They can put you on a blood thinner. As I said, most patients with coronavirus should end up on blood thinners. Those in the hospital, that is, should end up on blood thinners anyway. So don't stop taking your Hemlibra. If you get hospitalized, let your hematologist or make sure they contact your hematologist.
Okay. I'm going to post that on Facebook. So this is sort of like our wraparound $1 million question. Generally speaking, what are some of the sub-management recommendations you have for people with bleeding disorders who might get hospitalized or who are hospitalized for COVID-19? I think there's a little bit of a concern out there. You know, I'm really sick and I can't get to my HTC, or I'm not seen at an HTC. I'm taken to the community hospital, perhaps in a rural area. Concerns about if they find out I have hemophilia, maybe they won't intubate me. Or maybe they will intubate me and they won't factor me up and I'll get like a throat bleed or something. And then something that is really trending big time right now, I think a lot of us have read the Washington Post article that's come out, that there are these microclots that are forming and causing the deaths. And a lot of people, lack of breathing, O2 sat so low, TPA, heparin drip, these are things that are sort of like scary to people who already have bleeding disorder. Is that something that you should take or consent to or argue for if you do get hospitalized? So I really kind of just wanted to hear from everybody. Maybe we can, again, start with Dr. Soni and just get your kind of take on just the first question.
Sure. For
But
the
alluding
first
to these
question,
topics, yeah.
sure. So for the first question, continue taking your factor therapy as prescribed by your hemophilia treatment center. For the second question and the subsequent ones, I think Dr. Young's already kind of summarized nicely the same recommendations that I would make, that if you are hospitalized, to then make sure that they do reach out to a hemophilia treatment center, that we are able to provide factor, getting you back to where you're not factor deficient. And then you could be placed on anticoagulation medications. So I think at that point, if you're on the anticoagulation medications, there really should be a discussion in conjunction with a hemophilia treatment center provider. But very similar to Dr. Young's answer from earlier.
Should your levels be at 100% if you're having to go that route, or?
I think I'd be interested to hear what my other colleagues say. I don't know if you necessarily need to get all the way up to 100, but it should be at a higher range. So I don't think getting to 50% would cut it. I think you probably need to get closer to maybe 80% to 100 in that range.
Yeah, I agree with that. So if you do end up getting hospitalized for coronavirus, then you definitely should, in my opinion, you should be getting clotting factor. But with serious infections, as Dr. Young alluded to earlier, they're actually having lots of problems with clots. And what it's looking like is that some of them may be developing what we call this sort of a catastrophic antiphospholipid syndrome.
Mm-hmm.
And that is problematic. And that's where they would need to be put on anticoagulation, because that syndrome predisposes people to developing clots in bad places. And so at this point, and this is actually what happens in patients who need things like cardiac stents, you need to balance your clotting factor deficiency with the anticoagulant that they need to put you on. And so at that point, if you need to be on full anticoagulation, then I would suggest to keep your levels at a higher normal level than 50%. I would shoot for 80 to 100%, because that way you're considered a little bit more normal. You don't have a clotting factor deficiency, so your risk for bleeding from your factor deficiency won't be as high. I don't know, some other people might, outside hematologists will actually, my experience with them is that they shoot for the lowest level. And I've always had to sort of argue with them, no, please use a higher level and use more factor, because you're getting them to 50%, 8 to 12 hours later, they're at 25%, and they may have bleeding then. So I shoot for a higher level to start with and try to keep them above 50% at any given time.
Okay.
Yeah, I would just add that, so obviously hemophilia is a disease where your blood doesn't clot properly. And so there are some studies that suggest that patients with hemophilia are at low risk of blood clotting, disorders or diseases or problems. However, this illness is very new. This coronavirus illness is new. As we've already mentioned several times, and just in this last answer, that blood clotting seems to be one of the serious issues that gets people very sick with coronavirus. The only additional comment I would say is that just having hemophilia, let's say you're on factor VIII prophylaxis and you get sick with coronavirus, that stopping your factor is not the same as continuing factor and being on a blood thinner. The way blood thinners work and the way the absence of factor works is different. And so I think that because we don't know if just letting your hemophilia sort of be is going to protect you from the blood clotting issues with coronavirus, the better strategy, and both Dr. Kwan and Soni said the same thing, is treat your hemophilia. I agree with the 80-100% aiming for that, and then have the team put you on blood thinners if they feel that you need to be on a blood thinner. The other thing, somebody mentioned here, TPA. So let me say two things. One is, we don't have really good randomized studies yet on blood thinners. There's been hundreds of studies published, by the way, on coronavirus. Most of them are not randomized controlled trials, which is really the only way to prove something. However, the amount of data already published on blood thinners is such that even without a randomized controlled trial, it does seem as if being on a blood thinner does reduce the chances of dying from coronavirus. So I think that's become a standard as everybody gets blood thinners. And then the TPA. So TPA is a clot busting drug. It's a little bit different than blood thinners. That's what people get when they have a stroke, to dissolve the clot instantly, something we definitely avoid in hemophilia if at all possible. But there was one interesting report where a group of physicians treated 21 patients who were literally at death's door. I mean, they were going to die in all likelihood based on just how severe they were. So they decided to, sort of do a what the hell, Hail Mary, and give them TPA. And actually within a few days, most of them, 13 of the 21, so about 2/3 of them got better and actually even went home a few days later. So it was something remarkable about that response. So that again, it's a small sample of patients, but the fact that those patients were really like practically dead or going to die, and that this drug pretty much saved their life, even that small sample, it's pretty compelling. But that's, again, if it's something for hemophilia patients that we should avoid unless we're really in that dire situation. This is not something to be like, oh, I have coronavirus, I'm not that sick yet, hey, maybe I should get some TPA. No, you shouldn't get TPA. If your doctors are considering to give you TPA, it's probably because they've exhausted all the other options and that you might die, and so they're going to give it a try, because it can cause severe bleeding in patients without hemophilia, and in patients with hemophilia it could be worse.
Got it. Wow, that's interesting. Thank you. The next question is for the pediatricians, and while this is unlikely, as Dr. Young shared, okay, two questions. First, if you have an 18-year-old, 19-year-old, I mean, we're talking still like seniors in high school, they get a pretty bad case of corona, have to get admitted, or maybe they have to get admitted for a bleed. Are parents allowed to go with an 18-year-old or older child, or do they have to go by themselves? Because now there's these new rules. And then the other thing is, and again, unlikely, but there are all these clinical trials out there for treatment of coronavirus. It seems like it's the only way to get that the remdesivir drug or convalescent plasma, is that you need to get on a clinical trial. But if you're under 18, would you be precluded from that? So those two questions, if the pediatricians can answer that, or actually maybe Dr. Kwan too, but.
So at our hospital, at Children's Hospital of Orange County, if an 18-year-old patient does get admitted, we continue to admit patients up to 21, sometimes even above that. But right now, our hospital policy is that it would just be one parent. So we would have at least one parent to be with the patient. And when the parents change shifts, per se, it would have to be done in the lobby. the parents would then swap
Oh.
out from the lobby because we'd want to, again, scan the new parent fever questions that are routine at pretty much every hospital now. And
Okay.
then they come up to the floor. As far as the second question, clinical trials, I know some of the FDA already approved medications that are used for other conditions can always be written off-label to be used in pediatrics. A lot of what we do in pediatrics is off-label medications. As far as getting convalescent plasma, at our center, we do have a clinical trial open for
Oh,
patients to receive convalescent plasma. At our hospital, we haven't had any pediatric patients be admitted, but we know at our adult hospital next door at St. Joe's and also at UC Irvine, there are adult patients that are admitted. So we are collecting patients that have survived and overcome COVID-19 to draw their plasma, which will contain antibodies that they've developed to fight the infection. And then we do have a protocol in place to then apply that if we get to that point for a patient. And then there's different lab draws that we would do to monitor those patients along.
cool.
Yeah, I can just add, I mean, same rules at our hospital. If a patient gets admitted, even if they're older than 18, a parent can be with them. Obviously, so long as the 18-year-old agrees, because right, with HIPAA rules, the 18-year-old would have to be in agreement to have their parent participate in their care. I'll tell you that's not always the case. We have, some 18, 19-year-olds that, have difficult family situations and they don't want their parents involved, and that's actually their right. So I think that, as physicians, don't ever get offended if you're a parent of a 18-year-old or older. If we say, I do need to ask your son's permission. I'll say son because mostly we're talking about hemophilia. I do need to ask your son's permission if I can speak to you about his care or if we can discuss his care. Obviously the vast majority of 18-year-olds are going to be fine with that. But just so that we can make sure that we're following the law, we do have to ask that question. So if we do that and you're a parent, you happen to be in the room, just understand that that's our legal obligation. And I know there's more questions later or there's a summary about experimental treatments and things for coronavirus. So I'll reserve my comments about that for later.
Quick question on this point. Are the parents screened for coronavirus when they come to stay with their children?
So we had
Go
a
ahead.
patient that was admitted that was a rule out coronavirus based on some CT scans. Actually, the patient had a bleeding condition and had blood in the lungs. So that patient's mom had a coworker who was getting ruled out for COVID-19. So the hospital at that time advised the mom not to visit. However, now as we've gotten better with our testing, we would probably just test the parents to make sure that they don't have it before coming up.
Mm.
I think in some ways it's actually harder for the adults that get admitted because currently the situation is that no adult actually is even allowed visitors. So it's most difficult for example, patients that are altered. I had a patient who had a stroke and she could not have her family there to support her. And it was very difficult. So quite the opposite. And it's the same thing, UCLA does not allow more than one parent. So one parent at a time.
Yeah.
I mean, as far as testing parents, if we have a patient who tests positive, then we will test the parents. For parents who are symptomatic but don't have that connection, we're being a bit more judicious about the testing, although we have the capacity to do 1,000 tests a day now. So I don't know why the lab is being a bit restrictive about that. But no, if a patient is admitted with coronavirus, we can test the parents and make sure that, whether they are or not safe. The situation though is so fluid that you could test negative, one day, but then a couple of days later be positive. So, got to take the test result with a grain of salt, especially if you've had a recent exposure.
Someone did ask if they can go into their HTC and get tested for corona, or
We don't have the tests at at our clinic, we don't have it, but we'd have to refer them to UCLA for the tests.
Yeah, at our
test.
CIBD, we don't screen the patients. The testing would have to be done at a different location that constantly changes. So we would update the family if they were to call us to get testing on where to go to get testing.
Yeah, I mentioned earlier we have a drive-through testing area at the hospital. However, you do have to have certain qualifications to be tested. In other words, you need to be symptomatic. So yeah, if one of our patients was exhibiting symptoms and they came to the hospital, we would be able to get a test for them. And our test is done on site, and the turnaround time is generally about 3 hours. We'll have a result.
That's great. I do want to add to the person that asked that question from personal experience. If you do live in LA County, you can go on the coronavirus-la.org website. You do have to be symptomatic, but they will give you a test time pretty much the next day. It's free, it's drive-through, it takes like an hour. It took us 3 days to get our test results back. That was the only thing. And it is in the mouth and not the nose. But they do have those drive-through testings available, at least in LA County. I'm sorry, I don't know about the other counties, but thank you for that. Okay, just gonna switch and kind of go through this quickly because we really want to get to Erica. But what about gene therapy? Okay, what's going on with these clinical trials? This is a question for Dr. Kwan. Also, the question arose like, if I am on steroids with my gene therapy, am I also going to be at greater risk?
Yeah, so yes, you would be slightly greater risk because your immune system is being suppressed. So yes, the short answer is yes. And there has been a lot of talk with the different gene therapy trial sponsors about some guidance on what to do with the steroids. And it really is up to the individual investigator to try to taper the steroids as safely as possible, because you're trying to keep their factor levels high enough, but you want to make sure that their liver function tests aren't elevated. And so that's one of the reasons why people go on the steroids for during the gene therapy, is that you get a rise in the liver functions, indicating some inflammation in the liver. And so they use the steroids to try to control that so that they don't lose the factor VIII function. And that's sort of the simplified version of it. And so they are at increased risk is the short answer, but we do try to taper them as quickly as possible and try to decrease that risk as much as possible. We also try to encourage them to do all the safety things that we're encouraging other people to do, social distancing, stay away from people that could potentially infect you, that sort of thing. So that's sort of the short answer. I think every site is going to be different in terms of what they're going to require of their patients on the gene therapy trials. So for our site, because our centers essentially closed for routine visits and only doing urgent care, the clinic has been rather quiet. So I feel like it's a safe environment for the patients to come in. And if they're comfortable coming in to have their lab draws as scheduled, then we will have them come in. If not, the sponsors will offer them to have a nursing agency go out to their home in order to draw the blood. But that means people will have to be comfortable with somebody going into their home to do that.
Yeah.
And so some people have reservations about that.
Sure.
So they have offered the sort of, it's an allowed deviation from their protocol to not do the follow-up, but then again, you're balancing that with what to do with the steroids. So it's just all a balancing act, and every site might be different about how they want to handle their patients on a clinical trial, just in general, not specifically for gene therapy even.
Okay, actually, that was my next question for Dr. Yo, about the other clinical trials. Is everything on hold? That's what I heard. Can't join any now, can't participate. What is the current status with that?
Right, so different institutions have different rules. But I
Okay.
believe that in general, patients who are already on a clinical trial, they are already receiving a drug. So we have a patient on fitusiran trial. We have
Mhm,
pups on long-acting factor trials, and we have
mhm,
several patients on gene therapy trials.
mm.
The reason why those patients, the reason why you have study visits is primarily for the patient's safety. Yes, we get labs to understand how the factor is working and how the fitusiran is working and how the gene therapy is working. But the primary reason why we have visits during clinical trials is to protect patient safety. And therefore, it is my hospital's opinion and my opinion that those visits should continue to happen. The sponsors have given some flexibility to say, well, if a visit has to be skipped, we're okay with that. But thankfully, at least in our hospital, patients already receiving drugs for trials or who have received gene therapy, we are allowed to see them, and we carry out their clinic visits and get their lab testing to be sure that things are going along well for them and that things are safe. However, for patients who are not currently on a clinical trial, we are forbidden at this time from enrolling them onto a clinical trial, with rare exceptions. One exception, of course, would be if you're on a trial for coronavirus. Of course, you can get on a trial now, right? And Dr. Soni mentioned their convalescent plasma trial. So obviously, clearly, those trials have to go on. But in terms of purely hemophilia trials, I would have to make a very strong case why a patient really needs to get on a clinical trial. So, right now, I'm not in this situation, although I might be soon, but if I have a hemophilia B patient with inhibitors who's bleeding a lot and who may benefit from one of my clinical trials, I could request an exception to say, look, this patient's really suffering. They're having a lot of problems. I have a clinical trial that might help their hemophilia, and I'd like to enroll them. So in
Got it.
exceptional cases, I could appeal to do that. But generally speaking, new enrollments on trials are on hold. Also,
Okay.
companies that haven't yet started their trials, that were close to starting but haven't yet started, those things are currently on hold as well.
Okay. That's really great information. We actually have a link on our website to clinical trials, and we better update that immediately. Okay, this question is for Dr. Soni, and it's a question that is not so relevant, perhaps, but very near and dear to our hearts. Can asymptomatic people who are infected with coronavirus, you mentioned 40%, I thought the number was, we're talking about blood donations and encouraging, can the virus be transmitted through the blood donations?
So as the U.S. Surgeon General has recommended, you can still go out and donate blood. And looking at infectious risk, if you were to pass it along in the blood, it's important, according to the Red Cross website, I was looking at this earlier, it's important to emphasize that there are no data or evidence that this coronavirus can be transmitted by blood transfusions. And there has never been any reported respiratory infections that have been passed on through blood transfusions.
Great. That's good to know. And we are going over time, so if you have to go, you can, but I think there's still quite a number of people on the call. So, okay, this is the last question for the doctors, and then we're gonna move on to Erica. And we don't mean to put you on the spot, but maybe you do have an opinion. A lot of experimental, I forgot how many Dr. Young mentioned. Which one do you think, sorry, is the most successful? And then the second question, I heard Dr. Young talking about this before, and there are questions that are coming in about this antibody test. First of all, what the heck is it? And how can I get it? And if I test positive, am I home free? I can go run around, go to work, go shopping, and get rid of my masks. And then last question, but can I get it again? So what, I know the data isn't clear, but what are your thoughts?
Well, I'll start with maybe the clinical trials that seem to be successful. So first of all, you know, regardless of your political bent, you know, we know that President Trump pushed the hydroxychloroquine very strongly. And now as some of the clinical trials are coming out, it looks like A, it doesn't work, and B, actually it could be harmful. So that's a good lesson in that we have to do the clinical trials to really know. I would say that the one study that has shown some early data, and I think they're going to do their final readout later in April, and there's several places doing this study, is the antiviral drug remdesivir. And that seems to be a very, very good drug for this particular virus. So I guess what I would say to the audience is, you know, God forbid somebody in your family, or God forbid you end up in the hospital. If somebody offers a clinical trial to you, if it's remdesivir, I would say yes. And now some of those are still randomized. The sickest patients actually aren't randomized. They're getting remdesivir. The patients who are moderately ill are getting randomized to receive remdesivir or not. But I mean, if I was sick in the hospital and somebody came up to me with a consent form and said, hey, we're doing a trial on remdesivir, I would say, yeah, where do I sign? I think anything else is a bit still murky. So I'll stop and see what the other docs think.
I think the other one that Dr. Soni mentioned was the convalescent plasma. So both UCLA also has the remdesivir as well as the convalescent plasma trial going on. So that might be the other thing that could be protective. And those are the two that are sort of my leading ones that if I had to choose one or the other, I would choose one of those two at this time. I agree with Dr. Young. You know, the clinical trials have not borne out the effectiveness of the hydroxychloroquine. And that, again, that emphasizes why these clinical trials have to be done before we as physicians can recommend anything. The other one that I thought might be interesting, and I don't know other people's thoughts, is the one that it's a phase 3 trial with one of the rheumatologic drugs that stops the cytokine storm. I think it's tocilizumab.
Tocilizumab.
Yeah.
Tocilizumab.
Yes, and so that one I think looks interesting to me. So I'm not sure if I would choose to go on it. I would probably want the remdesivir instead.
Yeah, I concur with my colleagues. The remdesivir or the convalescent plasma would be what options I would take if I was needing to sign that consent form, as Dr. Young pointed out.
Okay, thank you. I do want to say if you are on this call and you did have corona and recovered, there are places that you can donate your plasma. People are collecting the antibodies. Oh,
Yeah.
go down to CIBD, they'll take it. They'll love to take that.
UCLA will take it.
UCLA will take it too. Please consider donating your plasma and save lives. All right, really quick, this antibody test. So where can we go get this antibody test to see if we've had it before?
So I want to start by saying there are about a dozen different antibody tests on the market. There is what we call the pregnancy test version, which is almost like a take home. Not that you can take it home right now, but it's basically it just looks like a pregnancy test. You do a finger prick of your blood. Don't put urine on it, that won't work. You put a little finger prick of blood on there and the blood gets pulled across. And if you have the antibodies, it lights up. That test is not quite as sensitive as the other ones. It's about 85% sensitivity, which means that if you've been infected, there's an 85% chance it'll be positive. There are other somewhat more sophisticated tests that can be done in a laboratory. So at CHLA, we have a test from a company called Urimune, which looks like just about the best test out there. There's another company that has a similar one where both something called sensitivity and specificity. I won't get into the details other than to say that they're very, it's measuring highly accurate assessments. So in other words, if that test is positive, it means really it is positive. And if the test is negative, it means really it is negative. And so we have that test at CHLA. It's only being offered now to people who've definitely had COVID or people who are suspected of having had the COVID infection. So, I mean, if you're a patient who's around CHLA, if it's a child of yours up to 18 or 21 and you think you might have had it, we can organize for you to have the antibody test. The antibody test is going to say that you've been exposed to the coronavirus. We don't yet really know for sure, if that means you're immune. I mean, generally speaking, it means you are. Viruses trigger these strong immune responses. And if you have an antibody, for example, if you have an antibody to measles or varicella, chickenpox, or other viruses, you probably are immune. So I think we believe it's true, but of course, there's no proof yet because it's early on. So I'll let the other two comment on any other things that I missed with respect to the antibody test.
No, I agree that at this point, yes, we can organize to get an antibody test at UCLA. And if you test positive, will you be protected? That's actually an unknown right now. We presume, as Dr. Young said, that it could, just like the measles or chickenpox, these viruses, but that hasn't been proven yet. So we can't say for sure, for any certainty right now.
Yeah, I agree with my colleagues on all of their above statements. At CHOC, the antibody testing is still getting vetted, still getting approved, but they do have the tests at St. Joseph's Hospital as well as UC Irvine.
Great, thank you. Last question for the doctors, and perfect segue into Erica, who may also want to answer this question. A lot of people making masks. Other things, is that helpful for you? Also, are there other things that people who want to help, what can we do?
If you want to make masks, that would be greatly appreciated by all of our hospitals. I know at CHOC, it's now a policy, as the others have illustrated at their hospitals, that everyone coming into any of our buildings has to wear a mask. And if a patient obviously isn't going to have a mask unless they make their own. So there have been families that have donated masks,
Nice.
as well as other medical supplies. We've had donations of N95 masks, as well as regular surgical masks and gloves. So if those are also available, those would also be appreciated, as well as the usual social distancing, 6 feet.
And actually, blood donations would be greatly appreciated. I'm sure UCLA, American Red Cross, anybody who's been a regular donor should try to continue to donate. I think that they're trying to be very safe, and again, separating people, screening them, making sure that it's a safer environment to donate.
And also, if you can, donating to your local food bank. That
Oh
is
yeah, the food bank is a big deal right
extremely
now.
helpful right now.
Really short.
Yes, so if you have the ability, I would definitely recommend donating to your local food bank. And you can go online and find various local food banks that are in great need.
So do you just Google food bank, Los Angeles, food bank, or like?
It depends, yes. So there are the larger, and I think I listed them. I don't know if you were able to upload those, Michelle, but for instance, I'm located out in the Inland Empire. So there's the main Inland Empire Food Bank. There are various food banks in LA County as well. And if you don't know of any, reach out to your HTC. We'll be more than happy to direct you to your local food bank for donation purposes.
Okay, great. Perfect segue into, we're hearing a lot of very difficult stories right now. And so Erica, with all your experience and, especially being at an adult treatment center, can you just talk a little bit about people who lose insurance to their jobs and what's going on with that? And also where people can just get groceries. Of course, we are giving people food cards now, but it can only go so far. So what can people do about that?
Right. So a lot of what I'm seeing is, I am at an adult treatment center. And so a lot of the things that I am seeing come through in terms of our patient population, I think in general, of course, is the job loss. And so the first thing I always say is reach out to your HTC so that you can brainstorm with your social worker on site, and whether it's in most cases through a phone call. I think most social workers right now are working remotely, but again, so much can be done, despite the fact that we may not be in the clinic. So in terms of job loss, I think the first thing to stop and think about is, if I lost my employer-sponsored insurance, what do I do next? Again, talk to your HTC social worker to discuss the options. One of the options may be jumping onto Covered California. The application period, I should say, has been extended out until June 30th for Covered CA. Another option, of course, is to reach out to your Department of Public Social Services. In the past, this was an in-person thing that you had to do. That is no longer the case. They are all closed, but they are accepting applications online only. Believe it or not, the process has been streamlined. So you can go to your, for instance, if you're in LA County, it's your LA County Department of Public Social Services. If it's in Orange County, it is CalOptima, right? And if you are in the Inland Empire, it is IEHB, for instance. And that is for your health insurance, to see if you qualify, for instance, for Medi-Cal. So that's an option there. Another option, of course, is to also speak to your social worker about jumping on board with GHPP. If you're an adult,
Yeah.
CCS for those 18 and under. I have always tried to encourage our adult patients to keep GHPP as a safety net.
Oh,
If
I'm
it is
going to go on to the
they
next.
can do, and if it's affordable enough to hold on to it, that way, if you lose your employer-sponsored insurance, you're still covered by that safety net, which is GHPP.
How long is it going to take to get onto GHPP if I didn't have it and I need to get on it right away? Is it like immediate or?
Believe it or not, they have been very receptive, Michelle. I have been talking to GHPP on a daily basis.
Wow.
Yes, they have
great.
really, yes, it's good to know. They are responding to email, getting responses immediately. Again, I think it's very different when it comes from the HTC provider versus the actual patient. And so this is why I'm encouraging patients to reach out to your HTC. Have your social worker advocate on your behalf. If I can give you a quick example, I had an adult patient reach out to me, lost his job, but still owed GHPP a renewal fee. And they have been extremely forgiving. They will either push it out into several payments or due to financial, they will even waive the fees. I was able to get this patient fees completely waived because of job loss.
That's really great.
Yes. So again, I know they
really good to know.
Yes.
So if they're not at an HTC, I know Cynthia has been helping a few people as well. So you can reach out to Cynthia, and Cynthia,
Yes.
I know, asks you for help.
Reach out
Also, I wanted to add about the food grocery question. A comment just came in from Brian, who's a school district nurse, and he said most of the schools are providing breakfast and lunch.
And lunch. Yes, excellent point. Thank you for that reminder.
And not checking ID. You can go to town, to school, and get a week's worth of.
Can I, honestly, you could, daycares are doing it too, and they're coming and picking up 20 lunches. You put up how many fingers, how many you need, and they will give it to you, no questions asked.
That's amazing.
Wow.
That is so great.
That's a great resource. That's a
So
great
that's a resource. And then just getting back to your Department of Public Social Services, it's sort of a hub, if you will, because you can reach out to DPSS for your Medi-Cal application. Getting back to the food, they also will assist you with the application for CalFresh, which is your EBT card. So if you are already receiving services, those services will continue. And if not, you can apply for both your Medi-Cal and your CalFresh at the same time.
Okay.
So that makes sense. It's sort of a one-stop shop, if you will, through your local Department of Public Social Services. Another thing I wanted to mention is this really nifty app. I don't know if I'm going to try to pull it up on my phone. It's a free app called Got Food. You probably can't see it. But Got Food. It's a free app, and you enter your zip code, and it will also point you to your local food bank. Totally free app, Got Food. It has a little red shopping bag logo, and you can obviously download that on any smartphone.
Oh, that's great. Somebody wants to know, do they need an appointment if they want to go to a food bank? And I'm not sure if that's for donation or picking up.
You do not need an appointment, but you have to be well aware of the times that they are distributing food. It is first come, first serve, obviously, but if you go online, they will show you the times where they are distributing the food items.
This is very helpful for us.
No appointment is required, though.
Okay, all right. Excellent. Okay, the recertification for Medi-Cal. This is
Yes.
great news.
Yes, same thing. So they thankfully are extending the recertification deadlines. So an example there is, let's say your recertification packet was due in March. They're pushing it out 6 months. So now you are good all the way until September of 2020. Same thing if you go down the line, you were due in April. It's not going to be pushed out until October, for May, November. So they're adding those 6 months. Also, to go back, GHPP is also extending those renewals as well. So if you're in need of renewing for GHPP, they're adding an additional 30 days for GHPP as well.
That's great.
Yes. So they're really giving everyone additional time, and it's much needed right now. Again, this is getting back to Medi-Cal. Your benefits will continue for the months of March, April, and May. Obviously, you still need to comply with the renewal process. I always let patients know, please just pay attention to what you get in the mail. A lot of us, perhaps, maybe if you're not stepping out of the house, please do so. Open up that mail. Medi-Cal will let you know what they need from you so that you aren't terminated after the 90 days. You still need to respond, basically. Even though they're pushing those deadlines out, at some point, that deadline will come and we've got to respond. But we're here to help, whether it's your HTC social worker or the foundation. Cynthia, I think we can all assist you with that.
That's great. And what is this?
So this is an emergency allotment that is being automatically added to the EBT card. So this is for individuals that are already receiving CalFresh. They are automatically adding this additional benefit. So for instance, I have an example. If you are, let's say, a single head of household and you're currently receiving $140 a month, you're going to get an additional $54. So the maximum will be $194 per month.
Oh, nice.
Yes, in CalFresh. That's for a single.
Okay.
Right? And so it's based on the number of individuals in the household with a minimum of 6 members per household. And again, this is a response to COVID. They're just trying to add additional money to that EBT card for families to purchase groceries.
Yeah, it really seems that that is the greatest need right now, is
Yes.
just getting groceries on the table without having to pay rent and utilities. I did want to say, if anyone is planning not to pay rent, you still have to provide written notice to your landlord. And in our last e-blast, there was a link to a sample letter that you could download and use as notice. Sorry, the lawyer thing is coming out, but that is really important. And there is some news that Cynthia picked up tonight from Mayor Garcetti's press conference about low-income rental assistance. I don't know if Cynthia's able to share because there wasn't that much specific news, but that's very exciting. Help for people who live in LA County. We have been looking in other counties. It hasn't been quite as robust.
Right.
Unfortunately.
So at the moment, it's only available for those in LA County, LA area. So if anything else comes up available in Orange County or Inland Empire, I will definitely post something up.
Thank you, Cynthia.
Great. Unemployment benefits.
Yes, so again, everything is online. Please keep in mind for unemployment benefits, though, it is taking some time to kick in. As you can imagine, the system is inundated, but they will process the applications. I think right now, all of the systems, all of the hotlines, I was on hold for 2 hours with Social Security this week. So it does take a lot of patience. They will eventually come on the line. They will process the applications, but there is, as you can imagine, they are inundated with applicants.
Yeah. I just want to give a shout out to Eddie Rosales. He is running a virtual 5K to raise money for the food banks. So if you want to donate, I believe he shared a link. Eddie, put that up on your Facebook and I will share that. It's awesome. Really, anything I think right now for people to help is much needed. I wanted to thank everybody. You know, we started out, I think, at 71 participants and we're only down to 54. So that is an amazing response. I think everybody was dying for this information, and of course, getting access to the experts and being able to ask questions. I do have one question that I wanted to float by that someone asked. My husband and I have been having a dry cough. We have a 16-year-old with factor 7 deficiency. Should I be concerned?
No
Not anymore
fevers?
Well, that's all the information I got. I'm assuming no fever.
I mean,
Without
think-
any
I-
other
I-
symptoms, probably
I think they're concerned a little bit about their child with hemophilia, with
Oh,
factor
factor
7
7.
deficiency.
Yes.
First of all, children aren't getting very sick with this, and I don't think the factor 7 deficiency is really an issue. So, I mean, if the parents do have it and the daughter does get it, I mean, the daughter will probably be fine, and I wouldn't be too worried about at least her, her health. I mean, the parents obviously don't have enough information to comment, but for the daughter with the bleeding disorder, I wouldn't be very concerned.
Michelle, sorry, can I add one more thing that we didn't touch on that I just wanted
Yes,
to
please.
remind everyone of? Mental health, behavioral health.
Oh, good one, good one.
Well, I think we're all socially distancing right now at the moment, but we should not be socially isolating. I think we all need to really remember that. But if you do find yourself, right, Dr. Young mentioned we need to be cognizant of our alcohol intake, very important. But again, if you are feeling extremely depressed, anxious, etc., your health for individuals again that are currently on Medi-Cal, for instance, I think many times families forget that there is behavioral health coverage with your Medi-Cal. You just look on the back of that card. There is a number there for your behavioral health provider. For instance, in LA County, it's Beacon Behavioral Health. That's just the large provider for mental health in LA County. They are offering free telehealth, mental health, one-on-one sessions with beneficiaries. So I'm really encouraging patients that are open to this to utilize it. You don't have to leave your home. You can speak to a licensed therapist. So again, just really taking advantage of the resources that are there. If you're feeling like you're really isolated and you need to talk to someone,
Excellent.
I encourage that.
Yeah, that's a very good point.
As Erica was saying, just because you're social distancing does not mean social isolation. I haven't done this, but I know my husband and his coworkers have. They do this sort of call-in happy hour Zoom kind of thing, and they all will have their gear together and see each other on Zoom.
Yep.
So,
Well, speaking of which,
not like I did it, but
I think we have segment 4 of our online women's virtual retreat gathering this Friday. Natural ways to boost your immune system. We're all going to dress up in our favorite Disney gear, grab your favorite beverage. So please
and
join us.
that's exactly
Friday.
it. You don't socially isolate.
Yeah, I just really wanted to give a huge round of applause for, I'm gonna stop sharing my screen so I can see everyone, just for our amazing doctors, our board members. I know, I'm so sorry, and people in the community know this about me. We're way over time, and I have like a phone full of questions. I don't know if you want to stay on and ask more questions or if the doctors have to go. Dr. Young, your dog is so cute.
Yes, I mentioned that, Dr. Young. I've been looking at your dog.
Sorry. Yeah, sorry. She came, she misses me, so she
At
came
one
into,
point, perched over your
'cause-
shoulder.
yeah, here she is.
There she is.
Lily, yeah. I'm gonna jump off. I have to actually get up really pretty early tomorrow, so I have a webinar actually at 8 in the morning that I have to get ready for, and I need to get a little bit of sleep. But Michelle, I'd be more than happy to, if this was popular enough, if there's more questions, to do this again in 1 week or 2 weeks, and
Yes.
maybe we do this
Yeah.
on some kind of regular basis, over until hopefully things calm down. So
Oh, thank you
stop
so much.
licking
I
me.
think we really appreciate that, especially as the information changes. And I
Correct.
did want to sing happy birthday to Dr. Casper, but she's gotten off because we've
She
gone
lost-
too late. Thank you. Everybody's saying thank you in the
I'm gonna
chat.
go.
Dr. Young, have a great night. We'll be in touch then about a follow-up webinar, and hopefully
Happy to do
Dr.
it again.
Soni and Dr. Young can join us. So, well, they say to end the event on a high note. So with that, I think we will come off and end the webinar tonight. I am so happy to see so many of you, and just a huge big kudos again to our amazing, amazing hematologists who are accessible and so supportive. We are very thankful for you guys.
No problem. Thank you for putting this together.
Yes, thank you, Michelle.
bless.
Thank you.